I'm going to finish the recordings for our Module 23, Cognition. I'm just trying to skip ahead on the slides here and get to 23C, Schizophrenia. Okay, here we go. So Schizophrenia 23C, page 1746 is where it begins. Profound neurobiological disorder, neurobiological. So look at your notes that I gave you for your study guide. It gets a little confusing if you're reading through the pathophysiology and etiology here. So I gave you distincts that you need to remember for this, because it's got familial, hereditary, genetic, possibly influence of environment, illness in the body, things happening during development, other things. There is, but they have psychotic symptoms, diminished capacity to relate to others, behaviors that appear odd or bizarre, impacts communication, cognition, attention, memory, emotional regulation, initiative, and social interaction. It affects everything. So your pathophysiology can occur in childhood, throughout later. It is usually exhibits adolescent to young adult. The college age disease is what it can be called, because that's when it often will exacerbate and demonstrate. Structural anatomic alterations, neurotransmitter abnormalities in the dopamine system. That's where your antipsychotics come in, your nicotine acetylcholine receptors. That's in your parasympathetic nervous system, so that impacts your pharmacological management. The exact cause is not understood. There's predispositions and combinations that lead to it, myelinization and reorganization of neuronal structure. So it is a neurobiological disorder. Risk. Risk factors. My papers are all mixed up here. Risk factors: genetic. Almost 50% risk with an affected first-degree relative. It's like individuals with an affected third-degree relative, such as a cousin, have a 2% risk. And then second-degree relatives, aunt, uncle, have sibling, up to 6% risk. So there's definitely a familial genetic something. No identification of markers. 60% of the disorder have no known family history. They think that there can be external modifications to the genes, but it's definitely genetic. And increased early life adversity, increased risk in children and adolescents who display certain alterations in emotional, cognitive, language, and motor development. So you have your positive and your negative features. If you look at page 1749, actually your text goes over it in 1748 to 1749, but I like figure 23.7 on how it goes over these. So you have your positive symptoms. I'm trying to find my slides. They're totally mixed up here. These are your psychotic features, are your positive. So hallucinations, delusions, motor symptoms, disorganized thinking. Hallucinations are most often auditory. Your delusions, false belief due to faulty perceptions. The person has a false belief that could occur in real life, but they're not otherwise impaired. Addition to normal experience, oculomotor abnormalities, grimacing. That's your motor symptoms, problems with motor sequence and coordination. So you can look at this little chart they gave you on here. Also, your negative symptoms, these tend to persist throughout the disease process, no matter what phase they're in, and even if you have the positive psychotic symptoms managed with pharmacology, they will still demonstrate negative symptoms. This flat or blunted affect, thought blocking, alogia, which is poverty of thought and speech, anhedonia, inability to experience pleasure. Avolition is a lack of motivation or initiative. If you look at your clinical manifestations on page 1751, it's really good where they have your positive symptoms, your negative symptoms, your cognitive, your manifestations of these, your clinical therapies. I think I talk about this in your implementation, but anyway, cognitive symptoms. So using lists and organizational aids. Your negative symptoms, which persist, they have poor personal hygiene is a big one there. So even if they're managed with their psychosis, they're still going to have poor personal hygiene. So your cognitive symptoms. I have some highlighted here. Prone to sensory overload, poor facial recognition. That's called facial agnosis. I gotta find it. Agnosia, page 1749, under your cognitive symptoms. So they don't recognize faces, even if people they would know. So name tags come in handy there. Prone to sensory overload, so you want to decrease stimulation, pull them away from overstimulation, or lower the lighting. Clinical therapies. You need to be familiar with your clinical therapies. That goes distinctly with your positive, negative, and cognitive. So cognitive behavior therapy, pharmacological, social skills is huge. Doing group therapies, using lists, name tags. Occupational therapy is significant because of teaching them about their ADLs, giving them structures and ways to be able to function, giving a routine that they need to follow. Greater risk of suicide in the schizophrenic male, but there is a high level across schizophrenia with suicide. Phases of illness. I don't even remember if I asked questions on this. If I did, it'll be on your study guide. So your premorbid, non-specific emotional cognitive delay, prodromal symptomatic period continues until psychotic symptoms start to appear, where they have social withdrawal, decreased functioning. I knew a young man, it was one of my son's best friends, and he started at age 15, 16, 17 with, well, the emotional and cognitive, they had him in special classes in like 5th and 6th, 7th grade because they couldn't quite pinpoint what it was. And by 15, 16, 17, he started having these odd concentration withdrawal and getting some paranoid issues. And between 17 and 18, he went into this floored psychotic positive symptoms. And then they can stabilize at sometimes. Maintenance phase is rehabilitation, return to level of function, status, and cognitive and negative symptoms may still persist even though the positive symptoms have stopped. Comorbid is a huge issue. Look over your comorbid is on page, it's in here, let me find it. No, it's going back far enough. It's on page 1750. Increased risk for cardiovascular disease, diabetes, COPD, infection. Women have higher incidence of medical problems. Substance abuse, almost 50% of people with schizophrenia, 25 to 60% have comorbid depression, up to 90% have smoking, tobacco use disorders. They have no social skills and no self-care, so they have poor dietary habits, social isolation, increasing their depression, poor eating habits, so they don't exercise, they isolate, they're sedentary, they smoke, they may use drugs or other substance abuses, so you're going to have the diabetes, cardiovascular disease, COPD issues. Antipsychotics also increase the risk for diabetes, increase their hyperlipidemia, lipid levels, and that contributes to the glucose, so it's a vicious cycle. 50% of people with schizophrenia have a comorbid, or they have a dual diagnosis of substance abuse disorder. Pharmacological management. Pharmacological management with schizophrenia is your first line. There is no cure. There's no cure for dementia, Alzheimer's. There's no cure for schizophrenia. Just trying to manage symptoms and keep them as functional as long as possible. Adherence is challenging. The biggest goal, priority that you have for their management is compliance with medications. 60 to 80%, I think 80% is more accurate for relapse rate for patients who discontinue their pharmacological management. Symptomatic management, orient as needed to person and place, avoid overwhelming overstimulating, remain calm and consistent, always inform patient before touching them. These are clearly stated in your symptomatic treatment on page 1757. And then you've got your family interventions, which are huge. Reduce relapse up to 20% using I language for positive feelings, negative feelings. This is clearly explained with examples in the little patient teaching section on communication for family members on 1757. Engage in active listening, make positive specific requests, and oops, I thought I had another slide. Didn't I have one for educate? Did I skip that slide? I did. Inform on course of disease, discuss therapeutic options, educate on potential medication side effects, which I discuss in your pharmacological recording, teach signs of relapse, evaluate the patient and family communication, coping skills, very important communication and coping skills, encourage healthy lifestyle behaviors, social skills training, implement boundary settings. Okay, so I had skipped that slide, so we're done here, and this is the end of this recording.